I'm really excited to kick off the first panel with Dave Kelleher. So I've known Dave for at least a decade now, and Dave is retired, although I don't believe that for 1 minute. He's always working on something and has been a great supporter of the forum. He was the original founder of the forum, and he served as CEO from 2001 to 2015. There are very few things I think that we could accomplish at the forum without Dave and his help, and I can't say how much I appreciate everything he does. I'd really like to introduce Dave up to kick off our afternoon panel. Thank you.
Well, thank you. So we don't have slides, so I'm going to move this just a little bit. So this morning, what we've heard is an awful lot of information. You know, Chris Whaley gave us an overview of the pricing across the country and integrated that partially with quality information. And then we had Chris and G talk about the prices posted by the hospitals in substantial detail. We had Marilyn coming at the issue from the cost side and asking the question, what employers need to pay in order to break even, and maybe promote a discussion between that and what they need for margin. And then we had Melissa and Debi approach the issues from the quality side. And so the question in this panel to start with is, and I don't want to ask it specifically of the participants, but is how do you pull all this information together and decide what to do with it? I mean, it's a huge amount of information, and each area represented by the panel speakers up here. So as we ask specific questions that came in online or we receive from the audience here, at the back of the question is, how do you use the data? You might ask, I'm going to ask some specific questions of individual panelists because Kristen organized this by person, which was really good. But at the end of that is the outstanding question, what do we do with it? So with that said, I'm going to start off with Chris Whaley. And a couple of the questions were, some hospitals claim they're paid less by Medicare than hospitals in other regions and states, and that's why prices look high. Is there any validity to this argument? And there's another one linked a little bit to his presentation, is the trend for market share versus relative prices statistically significant? Chris, you want to take up the mic?
Sure. Thanks. So for the first question, the answer is similar to how I responded to the online question earlier. It is true that Medicare pays some hospitals in some regions more, which reflects that it costs more to operate in some markets, and many hospitals do additional services that goes beyond just providing healthcare services. And so when you compare percent of Medicare, a given dollar at one of those hospitals that performs these extra services, looks like it's going further than at a hospital that does not do these additional services. And so many employers may say, look, if it's in a high cost of living or hiring area, we're comfortable paying higher prices. Others may not, and that's why we also did this additional approach of looking at standardized prices, which again doesn't adjust for any of these Medicare specific payments and just compares the intensity of doing one procedure versus another to make sure that we're kind of equitably comparing across hospitals that do different types of procedures. For the second question, the relationship between prices and the share of patients that come from non-private insurance sources is not statistically significant. So we find no relationship between a hospital's price and their share of non-private patients. The relationship between price and market share is statistically significant. Is, yes.
Is, okay. So thank you. Any follow-up questions on that for Chris? If not, we'll go to G and Chris Severn. The question from online was, price information to patients has been pretty ineffective in the past. Castlight is just one of the efforts that didn't do much. How do you overcome that issue with the future product offerings? And I don't know who wants to start, G or?
Go for it.
Oh, okay, go for it.
I think eventually the product usefulness has to really bring value to the consumers and to the employers, right? That's on the driving force. And to do that, I think there's also some fundamental structural challenges we have to address. First, like yesterday and this morning, we talked with especially Gloria's group, we have to give the consumers more skin in the game. Right? If the consumers if we're using other people's money, we don't care, right? Has to make consumers benefit if they choose more affordable care, and then the employers the same, right? If you really care, if you want to save your money and make your bottom line better, then focus on that. So I think more skin in the game, and then keep that product available on the market, and that is the right direction to go.
Okay, Chris.
Yeah, so what I'll add, we get asked this question all the time. Love Castlight, love what they did and what they're doing. I'll boil it up to a few things. The first is data use restrictions. So when Castlight got started, the laws were different. There were a lot more restrictions on what the data could do and what data you could use and how you get the data. Now, there are no data use restrictions with this new federal data. And so that means that you don't just put the data in front of the consumer, you could put the data in front of their referring physician, in front of that care navigation app, in front of folks that help the consumer make a decision versus putting it all on the consumer. One other really interesting piece of the new payer rule is MLR implications for fully insured plans. And so I know that's a nugget that CMS wanted to throw in, that, if you capture the shared savings distributed to members, it has MLR implications under this new transparency and coverage rule. So those are two really big things. It's just taking some of the burden off of just the consumer, and then giving more incentives to the payers. And then the final thing I would say that's really different is if I'm a consumer, and this is one of Cynthia's favorite things to talk about, and you tell me that this service is estimated to cost between $200 and $400, what am I supposed to do with that? It needs to be, down to the cent, $232.11. And this quality, this far away, available at 12 p.m. tomorrow. And with some of the new data out there, we're getting much closer to that perfect kind of value proposition to the consumer.
Okay, Marilyn?
Thank you. Just to add one thing is the role of the TPA or the insurer, the middleman there. Because if you're a consumer and you need a knee replacement and your deductible is $4,000, and you go to one of these tools and you find out it could cost a total of $23,000 at one facility or $50,000 at another, do you really care in most cases because you've met your out-of-pocket? You have no skin in the game. Do you make any conceptual thought of it might change my premium? No, you don't. So I think the role of the middleman in this needs to be looked at.
Thank you. I think that gets to the heart of that question, is who is the actor with this information? A couple questions for Marilyn. The first, is it possible to get a version of the NASB tool with the self-formulas available? That's one. And two, do you have any evidence to support the claim that commercial rates go down when government rates go up?
Ooh, two good questions.
And that you might share with Chris.
To be clear, if cost shifting is true, then the answer should be yes.
We don't find evidence in that. Thank you for clarifying that. I'm going, no, we do not find evidence in that. And the first one, we are not making public the formulas that are behind that tool. What we found when we first rolled this out is that a lot of mostly brokers or consultants, were using the tool and producing the information and charging for it. So we decided to back off, and we're not providing the formula. The tool's been quite enhanced since it first rolled out, and it'll be enhanced moving forward. And so we did not provide the formulas for that reason.
Anyone else comment on that second question? I think Chris actually hit that during his presentation pretty hard. Okay, a question from Melissa. Can we comment on the efficiency, the efficacy of incentive programs linked to HEDIS, NCQA, STARS, or quality gaps? Do we have any information that shows that the production of this information actually changes behavior?
So HEDIS is very different. So the HEDIS measures and the HEDIS program is used to measure health plans.
Right.
Which is different from the hospitals and the physicians, so you have to look at that. There is evidence that if you stop monitoring a provider or making them, submit data, that their performance goes down. So it's sort of,
The negative of that.
Yeah. So a lot of CMS will keep, or maybe, NCQA, who the HEDIS measures are a part of, may keep measures that we look at as topped out. So, you can no longer get any better performance. There may be some areas of disparities that they want to be looked at. But if you can provide evidence that once you stop monitoring, say, for lack of a better word, that the performance will drop. So some of these quality measures are considered to be important enough by various stakeholders to keep them around for that reason.
Okay. I'm going to broaden the question and look to Chris Whaley for some kind of a background on how some of these alternate payment mechanisms are function and are effective.
Yeah, I mean, so in terms of, most healthcare, especially on the commercial side, is paid fee for service, but we know that there are many innovators who have said, look, that's not how, a right way to align incentives. And so many payers have done things that extend from reference-based benefits and reference pricing, and that depends on leases range from, do you do reference-based benefits for colonoscopies, or all the way up to Marilyn's example, where it's just, we're going to reference price the entire site of care and everything that happens in a hospital, and just set a single price across the board. And so, as you might imagine, kind of the more you do, the larger the savings, and kind of the flip of say reference pricing or reference-based benefits, as many providers have said, we know that there's a tremendous amount of price variation that is in many cases not linked to quality for kind of big ticket items. So whether it's orthopedic surgery, imaging, et cetera. And so we're going to design special carve-outs that either use bundled payments or tiered networks to direct patients to high quality and lower price and the high value providers for these services. And in general, those do work well, and kind of there's lots of flavor in terms of how they're designed. One potential challenge is that we might get to a place where you've got a bundle for hip replacement, a bundle for cardiac care, for oncology, and that's just not making the healthcare system better, or at least easier to navigate. And so I think that the benefits of individual kind of service level purchasing really need to be weighed against the trade-offs of complexity. And in some sense the gold standard is as we've seen from Maryland's program in the state of Montana, is just to say, look, we're going to address prices across the board in one number.
Okay. And I'm going to go to Chris Severn now and ask a kind of follow-up. As you think about the contracting strategies that your company is proposing, how do you integrate the quality with the cost side of information in order to affect behavior?
Yeah, I mean, there's some literature on this, and one of the exciting things with some of the new price transparency data coming out is some of these APMs are being represented in the payer schema that's coming out on July 1st. So you can look at the whole spectrum from like fully capitated all the way down to, incentive-based payments. And we're going to see more of this from price transparency is our theory. What I want to get to really quick on that topic is what Chris just said with bundles, and there's a risk for some of these APMs that we just end up with a smattering of different bundles, where the bundle in Montana looks like this, the bundle for Anthem looks like this. And so with the proliferation of these price transparency tools and some APMs based on top of bundled payments, which a lot of them are, what we're really working on at Turquoise, and we invite a bunch of folks, is an open source effort to define a standard bundle, a standard library of bundles that we just call standard service packages, because we're worried about the same thing, some of the things that Chris was talking about, where it's really hard as a consumer or as a purchaser to make value-based arrangements or any purchasing decision on top of a proprietary bundle that you can't compare against multiple offerings. So that's the main thing we're seeing today.
And we'll jump over to Marilyn. When you started your intervention in Montana, how did you balance cost and quality, or was the information available at the time for you to consider both sides of the equation?
What we initially did is all of our approach was data-driven, and we definitely pulled. As a CPA, I looked at that accounting data, and so our price was, we knew a range we wanted to get to, and we did the price negotiations there. Now, we did not bring quality into the price decision. What we did do was contract with Healthcare Bluebook, who did model our payment system to their tool, so that then members and legislators, everybody else, could use Healthcare Bluebook to see if that end contract with that provider had come down into the green phase, or were they still yellow or red, because some we had to do a glide path on, and they could compare it to the quality there. So in the pricing decision, quality was not included. In the rollout, it was.
I'm going to switch gears a little bit and go to Debi and ask, as I understand the Quantros system, it's a combination of measuring quality and including reliability in your measures. And how does that trade-off work? And I hear also there's going to be a next version that you're going to be implementing, and could you tell us a little bit about that?
Sure. Yeah, so when we look at quality, we definitely keep in mind case count and reliability. And I know, like, the golden North Star is ASCs. A lot of procedures are moving to that ASC market. And currently the data we have is inpatient hospital. And so there has been the question of, if somebody is performing most of their surgeries in ASCs, they're either not scored or their quality scores may be less. That is a very true statement right now because of the data that we are using. We are looking at getting that commercial ASC data along with additional ASC data. It's ridiculously expensive, and so I don't remember, one of y'all talked about, I'm from Texas, talked about getting the all-payer state data and being able to use it. And we have had some of that data in the Quantros system, but the availability to use that is limited. So from a policy perspective, it would be amazing to be able to get that, because then we could provide additional quality scores and higher reliability for physicians who are practicing both inpatient and outpatient.
Okay, thank you. And I invite anyone in the audience, we've got a couple microphones out there. If you have questions, help us out. I have a question for G. And what would be the impact of the insurer's disclosure rule to be implemented July 1st? How are you going to integrate that with the information coming from the hospitals, or do you plan to?
Great question, thank you. And this has been a topic on the Hill as well. People are questioning, why do we have an insurance company disclosure rule while we already have a hospital rule? The truth is, once we have the insurance company rule, let's say everybody complies, then this hospital rule is already going to be obsolete, except for two things: the charge master price and the cash price. Many people believe the charge master price is not useful, but the cash price probably will be the the only thing that will be useful staying there. Yeah, thank you.
So Chris?
This is a huge topic right now. And if we dig in, this is something interesting about the hospital data. You're all experts, so let's talk about it. In the hospital's charge master, in these files that are being revealed, you'll have a long list of devices, which are often, implantable devices are often paid separately from a surgery. You can see in the description, whether it's Medtronic, St. Jude, which model, the payer data doesn't have that level of granularity because they just get, the CPT code or the revenue code. And so not only is it the cash price and the list price, but it's these descriptions in the charges that matter as well. Because if you're deciding whether to send, an employee to hospital A or hospital B, you would look at the price of that carved out Medtronic pacemaker at hospital A or hospital B that drives 50% of the reimbursement. So we hope that both rules stay in effect, even though there is a bit of overlap.
Do you expect to see the information coming from the payers to be mimicked? I mean, to be the same as that coming from the hospital?
No.
Okay.
But the fine is much higher for insurance companies. That is, I cannot have the number, but it's substantially high. So we expect to have a much higher compliance and accuracy in data reporting from the July 1st rule.
So are they going to be reporting in the same categories, the different products, the different prices? And you can match them up between what the hospital reported and what the payer, the intermediary reported?
In a perfect world, you could. The trouble is the schema definition doesn't yet exist for hospitals. And the hospitals don't know that granularity of, line of business, plan, and carrier. And so the payer data will be much more usable right out of the box, much clearer because of the defined schema. But matching them up is going to keep, our data scientists busy and probably a lot of people out here as well.
Super, okay.
Dave.
What?
Dave,
Excuse me. Oh, sorry, we got one from the audience.
The rules, Dave. I walked
Welcome.
up, but I'm really short.
I was looking for somebody to help me out
I'm a rule
up here.
follower. So we've heard about costs.
Your name,
and,
organization?
Oh, yeah, Denise Fields. So I work with Evernorth, but I'm the on-site pharmacist at the Cummins Livewell Center in Columbus, Indiana. So I'm an advocate for patients a lot of my day, somewhat, some case, not case manager, but I feel like that role. So the one thing I've not heard, we've talked about cost and price and quality and reliability. Chris hit on it in one of his statements, access. How fast can I get in for that service? So are you willing to pay more? Because if you're diverting, a majority of patients to a facility that is going to be good quality and more reasonable price, maybe the access to get that procedure done might take longer because their volumes are bigger. And now are you willing to pay a higher price? I live in a rural area and so was recently told it would be 3 to 4 weeks for a diagnostic mammogram. I had the ability to drive 2 hours to get one within 2 days. The people that live in my rural community can't do that. So what about access in this whole discussion with price, quality, reliability?
Okay, who wants to take that one on? Did you direct that to somebody that you didn't like? I mean,
Whoever can answer it.
Go ahead, Chris.
I'll go real quick. This is what I'm most excited about. I'll use the example of cardiology. If you need a cardiology consult and you're in a rural area right now, you got to drive to a hospital. And if you're thinking about the forces of price transparency and you're a cardiology telehealth startup right now, and you can serve those members in a rural area over an app, it looks really good. And you want to post your prices. You want to post that a consult's available at 11 a.m. tomorrow with Dr. So-and-so of this level of quality. So I'm very excited about that, just that competition of access and convenience inside of care.
Melissa?
So when you talk about access in the example that you gave, you also need to talk about equity and disparities, which you're finding, especially during, I think they've always been there, but COVID also led to that, right? In rural areas, and now they're finding cancer diagnoses that weren't because people delayed their care. But where I grew up originally in New Mexico, it's the same thing. You have to drive an hour to get to an emergency room, right? So when you talk about access, is also we can have a whole conversation, spend a day talking about equity and the disparities that go along with that. And it can have to do with like disparities around age. If you have telehealth, is somebody who's elderly, are they even, do they have the technology itself to be able to use it, or do they have somebody around to help them use it? Or, non-English speaking patients as well. So that leads into a whole nother discussion there.
Well, and we don't have an infrastructure in rural America for telehealth. So if the wind blows and I'm at home, I can't receive a call, let alone have an internet signal. I pay for 4 internet services, 2 satellites and 2 MiFis, and there's a lot of days where I could get nothing, so.
Okay. Do you drive up and down? You used to be, when I drove to Louisville from here, I'd see these signs that said, waiting time at our ER is 5 minutes.
Exactly, and that's what I'm thinking about. For access, can you start to advertise average wait times for not just ERs? Like with the price and the quality, what's the average wait time to get in for a knee replacement? What's the average wait time to get in for, a bypass, like
Right.
whatever it might be?
And there's
Primary care
Melissa.
visit, yeah, for a primary care visit, an endocrinology visit, behavioral health, like a neuropsych evaluation. Like I had a son that needed a neuropsych evaluation for ADHD. It was a 9-month wait. So,
Wow.
yeah.
So Melissa, aren't there access measures in some of those, the quality measures?
Not exactly. Some of them may say access, but they're more process measures.
I remember some of the HEDIS measures at least were called access measures. I wasn't sure.
So that's for the health plans, but that leaves out a whole population of people as well, right? You have to have a health plan. Like I am now have to buy my own insurance. So I look at all the health plans, how they're rated. It really doesn't mean anything because some of them are new. So they're not even rated, right? So there are no true access measures or cost and efficiency measures the way NQF defines them.
Okay. And I think Chris Whaley wanted to weigh in here.
Yeah, I think the other important thing to think about with access is just the context of how the healthcare delivery system is changing. So probably the most dominant trend in the healthcare system right now is hospitals and health systems acquiring physician practices. And as part of that, there's been a push that once a physician group gets acquired, that they refer all their patients to the healthcare system. And what we've shown in several studies is that actually leads to patients having to travel a lot further to get care, and so it's kind of our direct impact of access leads to barriers to care.
Thank you. Don, do you want to
Well, I
measure?
talked to Chris prior to this, so maybe that's where that came from, because that's my question.
Hold on a second,
your-
Don. Who are you
Oh,
and what
my name
organization?
my name is Don Stomp, and I'm retired. But available for hire. So in your correlation of hospital prices, has there been a study of the correlation of hospital prices with the percentage of physicians employed by the health systems? Because just as you said, Chris, I think it used to be physician ownerships of hospitals was not allowed. I think it was a Stark provision, or maybe it's a state law, but to avoid overutilization. But now we have the opposite, where hospitals acquiring physicians, all of a sudden those ancillary services are now 3 times the cost, because they've acquired those physicians. I don't know what the answer would be if we decide that that's not a good thing, because I doubt if you could regulatory change that, but has there been any studies on that correlation?
Yes, and as I answer that question, I will point to the Northwestern radiology slide in the back, where the first row shows the X-ray price is $350, but the independent price is $75. And so what we've seen in several studies is that when the physician group gets acquired by a hospital or health system, they send their patients for their imaging, their labs, and all these services towards the hospital and get charged the $350 price as opposed to the $75 price before they were acquired. And so we have this kind of balance where we may be worried that if you're a physician group and you own a facility, that you're going to refer patients to that facility. And I look at that chart and some of the other evidence that we've shown and actually think that, well, maybe that's actually a good thing and will reduce costs.
So Chris, how do you even know, the information that a system owns more physicians than another? Where does it show up? I was looking at Marilyn to see, I don't think it shows up on the Medicare cost report, but I'm not sure. But where do you get the data in order to try to make that analysis?
Yeah, so physicians and anyone who bills Medicare has to report their ownership information to CMS, and so we've been able to get that data from Medicare data.
And so you found a positive association between the physicians association with hospitals and the prices of those services, or are we talking about site of service changes that are driving that issue?
So we find evidence of both.
Evidence of both. Okay, so it raises the price and raises the price again because of the site of service change.
Exactly.
If I may add, so think about if you are a physician, by yourself, how much money you can get, right? And then how much money you can get if you join a group. So these are voluntary decisions. That means there's some structure or market promote physicians to join the group, right? Nobody's forcing them. And then think about small hospitals, the same. Once they join a big group, they have access to huge leverage. And then think about 340B program, all those, other, grant programs. Those are not available to small groups or hospitals. So our structure, our system, create a lot of incentives for small ones to leave their independent practice to join the big ones. So I think that's something the people on the Hill, we should talk to our policymakers to change.
Owning a physician practice is the arbitrage opportunity of the healthcare system in the U.S.
Own your referrals.
Own your referrals.
Okay, thank you. Can I?
Yes, Linda Wilgus, and I am with Northwest Radiology Network.
All right,
So,
I want that $75.
thank you.
I want that top price. I want the $75.
So I'd like to stay on this topic, if I could, and with this well-educated panel. So especially the slides that the RAND Corporation presented that Indiana physicians on average enjoy, if I could use that term loosely, 110 to 130% of Medicare on average. In the state of Indiana, I recently saw a statistic that 70% of all physician groups are owned by a health system, where the national average is more like 50%. So I'm wondering, question number one, if you can opine, if there's a correlation between the high healthcare costs and the high percentage of owning physician groups. And then second, what do you see that's working in other states that allow physician groups to remain independent?
Ooh, good question.
I'll just jump in real quick, the first question. So these decisions are all economically driven. On the surface about patients, coordination of care, of course, there are some merit to it, but fundamentally all economically driven for financial gains. And that's not surprising. We see many PE firms, once they own those systems, they have all kinds of sophisticated measures to improve revenue because they are really the expert. So my point is, there's a strong financial incentive to grab the physicians there and then negotiate together. So many systems now, they negotiate the price of the hospital and the physician group at the same time to improve the leverage and squeeze more money.
So I have a follow-up question for Chris Whaley on that. Do you see in the RAND information any? I don't know if you have to cross it with another database, but is there a correlation between physician ownership and the relative imbalance between physician payment and hospital payment? For example, in Indiana, we have high hospital payment, low physician reimbursement. It's kind of ideal territory to merge. Do you see that across the states? Or
that's a good question. We have not looked at that in our data, but that's a testable thing.
That is testable. Okay. Did you have a follow-up question?
Thank you.
Okay. There are some online questions,
Yes.
and Kristen is going to select some of the better ones.
We do have quite a few, so we'll get to a few, and if others have other questions, please feel free to
come up.
step to the mics. a couple this one might be more for Marilyn. Can you please speak about the break-even price? Why would it vary between neighboring hospitals in the same system? How does a hospital like Mayo Clinic keep theirs so low?
The break-even calculation is per specific hospital, and it is what a commercial payer would have to pay to cover their own costs plus all the other reported expenses of the hospital. Now, it is calculated at their reimbursement rate that they get for Medicare. If that particular hospital is making a large profit on Medicare, then the break-even's going to be lower because we're assuming you're already paying that Medicare rate. It will fluctuate by the payer mix. If they're losing a lot of money on Medicare or Medicaid, maybe the break-even's higher. If they're making a lot of profit, which I don't know for sure on the example given, but I would think that might be large investments that have a lot of return, then the break-even's going to be lower because they're already making that compensation.
Okay. Could you explain the 3 levels? Did you get into, I didn't.
Yeah, the actual tool itself, and the tool is online, that you could go access the tool and input the information yourself. And it produces 3 break-even levels. The first level is what would a commercial payer have to pay to cover their own patient costs and any shortfall on Medicare, or excuse me, on any public payers as well as uncompensated care. So that's the base level. And then we add a level and we say, okay, what would you have to pay if you covered all those Medicare disallowed costs, the non-operating costs, a lot of the joint ventures, research, other items that are not covered. So then you're fully costed out. And then the third level is let's bring in other income and other expense. So if you use the tool, you'll have 3, but what we chose for the online tool was level 3, which is the maximum.
Okay, thank you. Any follow-up questions on that? Okay, Kristen, do you have another one?
Absolutely. Several more, Dave, that we may have time for. Given patients are bound to their group insurer, how might they take advantage of better values from non-preferred or out-of-network providers? So basically, is there some type of strategy for using out-of-network providers? And I'll open that up to the group.
Okay. Who wants to grab the mic first?
I'll start. What I think is interesting is you can actually stay in network and find a high-value provider. So that's where providing that detailed information for a consumer to look to find the highest quality at the lowest cost. One of the last slides I showed from hospital for a knee replacement had the highest quality along with the highest cost, and that was all in network. So it really is choosing the right provider and going to the right facility. The other piece that I know we've heard a variety of people talk about bundles. So if you're in a medical desert, I call them, in Horse Cave, Kentucky, I have a client there and they need to drive to Bowling Green to get, or up to Louisville to get better quality care. We've helped them provide bundles along with travel services for some of those higher cost procedures where in Horse Cave they just don't have the medical resources. We can't develop the medical system, but we can help drive the members to higher value care through plan design.
Okay. Chris.
So that kind of hits this topic that at Turquoise we call it liquidity, but it's the ability, like the hallmarks of a competitive market, and the ability for a patient to go out of network. We think about all these like getting unstuck factors to create competition. One of these is if I'm going to go out of network, I need to get an estimate, but also I have medical records with my in-network provider. How do I get them to this out-of-network provider and then get them back? So when we think of supporting this world of liquidity and choice, it's how easy is it for a provider to break free from a health system? How easy is it for an employer to break free from their carrier or to come up with alternate payment arrangements? How easy is it for a patient to go out of network and then come back in network with the same documentation? So the reason I just hit those liquidity issues is if you're an entrepreneur out there, or if you're supporting that liquidity and that competition over the next couple of years, it's probably a good space to be in, because right now it's very hard to do that.
Totally agree. The competition and the fluid of information is the key. Think about the prescription drugs. Many of your members are already doing out-of-network things. Think about GoodRx, right? Mm-hmm. Yeah, your members would forego the insurance and go to the GoodRx to just pay so-called cash price, which is using an out-of-network PBM to give them a adjudicated price. So I would be surprised if we don't see that on other medical service market. Thank you.
That's interesting. Chris?
So think about the insured patient. They find it cheaper just to pay cash than they're out of pocket. I think, because so many high deductible plans.
Yep. So the drugs for my dogs are cheaper than the ones that I buy through my insurance carrier. Chris?
Yeah, I'm going to answer kind of a slightly different question. I think that we actually shouldn't use this type of data to put more burdens on patients. And instead, I think this data really needs to be used to inform employer and purchaser decisions on how to actually form the networks, and not say to the patient, look, you've got all this data, go navigate the U.S. healthcare system, good luck. And what we've heard from many employers as we've been doing these studies over the last couple of years is that, look, we as an employer, we want to design these networks, and we want to make sure our patients have access to low cost, high quality care, and everything's in network, but we just don't have the information or the resources to do so, and we don't kind of know what's going on under the hood. Now, as of 9:45 this morning, I don't think that truth or that excuse is actually valid. So I think there's really now the responsibility is on the employers and the purchasers to make sure that the networks they're setting up are actually fair and efficient.
Thank you. Okay, we have someone at the microphone.
Hi, my name is Alex Blow. I'm from Mathematica. I have a question for Chris. I'm curious about, right now we're referencing everything to for everyone, we're referencing everything to Medicare fee-for-service. But what's interesting is that while hospitals oftentimes are not as happy or use Medicare fee-for-service pricing as, this might be a loss, is low, what's interesting, plans really like Medicare Advantage, and the reason why is because the premiums are so much higher, and if medical loss ratios are 80%, 20% of a bigger premium is more money. So I guess the question is, what do these price ratios look like when you use Medicare Advantage in the same plan as a reference price for similar services?
Yeah, that's a good question. So another wrinkle of Medicare Advantage, which there's a potential that we could actually have the same effect for the No Surprises Act, is that if you are a Medicare Advantage patient and you go out of network, then the most that the provider can bill you is the Medicare fee-for-service rate. And so for the Medicare Advantage plans, that really just takes away a lot of the negotiation leverage that providers have to negotiate higher prices. And so we actually find that Medicare Advantage plans are essentially the same, maybe plus 5% or so of Medicare fee-for-service plans. And so if we were to do this percent of Medicare relative to percent of Medicare Advantage, the results would essentially be the same.
I also want to add, the fee-for-service also subject to all kinds of manipulation, right? Think about the subspecialty in radiology. I won't name the subspecialty, but some of them are very active in lobbying. And what happened if we had a study look at the past 10 years, then the average Medicare rate fee-for-service for some radiology subspecialty increased while some other dropped. All can 100% related to the lobbying effort. So my point, I really like your comment. Medicare fee-for-service price is also man-made, and does not mean that reflect the true price, right? So if you base on, let's say, 20%, you may be already paying too much. We're paying too much.
Thank you. I'm going to end it with one question for everybody, and this is a question about low-hanging fruit. What can employers do? What can employers do now with the least effort, using the newly available price and quality information to make a difference? And anyone who wants to take that on.
Let me start. I think I tell my MBA students always. Real quick, more skin in the game. More skin in the game. We won't care if you're using other people's money. If your employees understand they choose the whatever desired option, they will save money. They will do that. Done. Thank you.
I'll go next.
All right.
I think having been a plan administrator, I think looking at how you're tiering your benefits with the data that's coming in from this tool, from the SAGE tool, you're able to look at maybe the better quality, the lower costs, the more efficient hospitals, maybe to your benefits as far as the amount of copay, co-insurance, depending on, and provide some steerage. I think as an employer, you definitely take a look at some direct contracting with those. Pull them out of it. Pull them out of your middleman contract. Obviously, I have an issue. I keep calling insurance companies middlemen. But I think you pull it out of that and do some direct contracting, which would definitely help.
Okay. Someone else? We have about a minute and a half left.
I'll be quick because my focus is on quality only. I would say look at the quality data critically. So don't take everything at face value. Lift under the covers, take a look as employers. Have somebody with quality experience to help you look at that.
I got a quick one too. Low-hanging fruit that wasn't available before is you could take your utilization data and now run it up not just against your carrier, but other options with some of this new pricing data. And so you could come back and have a conversation with the carrier and say, in some markets and say, here's Cigna, here's UHC, and not just have a premium-based conversation.
Super.
Employers spend $1 trillion or over $1 trillion on healthcare and pay the highest prices in the world. A large reason for that is that they haven't seen what's gone on under the hood. Now they can actually have some insight into what's being negotiated on their behalf and what they're paying to have negotiated on their behalf.
And because everyone else spoke, I guess I need to. Mine is more challenging. I challenge the employers to not be afraid to take some risk. We're typically a very paternalistic group of people who don't want a lot of noise from our employee base. And I know it's less noise is best, but in order to make some significant change, we need to take some risks. And so I would encourage everyone to take a little bit of risk to help change the system.
Well, thank you. Let's give it up for our panel.